And we're live in 5,
4,
3,
2,
1.
Hello, good morning. My name is Cliff Pierre, neurosurgery fellow at the Swedish Neuroscience Institute, and I'd like to welcome you to our Cerebrovascular Question and Answer Symposium hosted by Seattle Science Foundation. It is my distinct pleasure to introduce to you Dr. Stephen Hetts, who's currently a professor of radiology, biomedical imaging, and neurological surgery at the University of California, San Francisco. After his medical school training at Harvard University, he then completed his medical internship at Stanford, and afterwards did a diagnostic and interventional neuroradiology fellowship at the UCSF, where he then joined faculty in 2008. He currently serves as co-chief of the neurovascular surgery at UCSF, as well as chief of interventional neuroradiology at UCSF Mission Bay Hospitals. He provides cutting-edge, minimally invasive endovascular surgery therapy for children and adults dealing with cerebrovascular diseases or tumors. He's co-director of the UCSF Hereditary Hemorrhagic Telangiectasia Center of Excellence that treats patients with vascular malformations of the brain and other organs. He's quite active in research as he serves as co-director of the Interventional Neuroradiology Research Laboratory. He's published over 250 peer-reviewed journal articles as well as book chapters. He's quite an active leader in the community of academic medicine, where he currently serves as also the chair of the UC Stroke Consortium, which is a collaboration of stroke research and care taking place at 6 major medical centers in the California. We're excited to see what his talk is going to be about today in the world of vein of Galen malformations, as well as other pediatric high-flow CNS vascular lesions. Dr. Hetts, thank you for joining us.
Well, thanks so much, Dr. Pierre and Dr. McDougall. I really am honored to be able to chat with you guys today. And I've put together a talk on pediatric vascular malformations. And so let me see if that is sharing for you guys. Are you able to see those slides?
Yes.
Looks great. Yep.
Fantastic. So again, we'll focus on high-flow lesions. My disclosures, none of which are particularly relevant. And so I thought I'd just start with a little bit about pediatric neuroangiography, and then go into some of the specific pediatric arteriovenous shunting lesions, and then we'll leave some time for questions. So for those of you who may be newer to the field, in children, we tend to use somewhat smaller angiographic systems. The typical setup is a 4 French sheath and a 4 French diagnostic catheter. You have to remember that these folks have low blood volumes in general, and so you need to be quite attentive to any heparinization that you use in your arterial drips. You don't want to overwhelm a young child with a lot of heparin. They do have very highly reactive arteries, and so ultrasound for access is a real boon. Because once you've hit an artery, if you don't get successful access, it often will go into spasm. And so you need to wait until it comes out of spasm. One thing that we do often do, particularly for slightly older kids, is put a half an inch or some other dose of nitropaste on their chest, and that sort of systemically dilates their arteries and makes them a little less vasoreactive. And then, of course, we do all pediatric cases with anesthesia support, which essentially means general anesthesia. One other caveat is that there are no neuroendovascular devices that are designed specifically for children. And so for those of you who are doing this, you're quite familiar with, using the adult size devices for the kids. The catheters are all way too long. The child is sort of this big and the catheter is, 1.5 meters long. Also, because their arteries are small, we're often using what would be considered adult intermediate catheters as our guide catheters in kids. And, for infusion cases like intraarterial treatment of retinoblastoma, for example, we'll just navigate microcatheters all the way from the femoral artery up to the ophthalmic artery without a guide catheter at all. And you can push against flow as long as you use a guide wire. So there are some modifications if you're going to be doing cases in kids as compared to cases in adults. And then because the kidneys in children do not have an infinite capacity to filter contrast, and because we want to space out radiation in very young people who are more vulnerable to the effects of radiation, it's important to stage procedures when it's safe and feasible too. So often we're not aiming for cure of a big vascular malformation in a single session. We're aiming to reduce flow, for example, and get the child out of heart failure, as we'll see in some of these cases, and then be able to sort of pick off other parts of the malformation down the road. So we'll start with sort of the canonical diagnosis, which is a vein of Galen malformation. And the classic description is, the child is delivered, and a few days after birth, they go into high output heart failure. This is a, enlarged heart in an intubated child. Here's a very old MR showing a large dilated vascular structure in the head. And technically, vein of Galen malformation forms early in embryologic development between week 6 and 8. And so technically, it's an arteriovenous shunt of the precursor to the vein of Galen, which is called the prosencephalic vein of Markowski. And, this is the classic congenital malformation. It forms in utero. And they can present clinically in sort of 3 different time periods. Actually, I should say 4 at this point, because now we do more screening. And so now they do present prenatally. And I'll mention a little bit about prenatal diagnosis and treatment in the mid portion of this talk. But the classic 3 times that they present are neonatally, again, shortly after birth, going into high output congestive heart failure because of the very large arteriovenous shunt. If the shunting is somewhat less than that, they can present as infants with hydrocephalus and a progressively increasing head circumference from underabsorption of CSF due to high intracranial venous pressures. And then if they have a somewhat less shunting than that, they can present later in childhood with developmental delay, seizures, and sometimes redirection of venous flow. So you'll see dilated facial and scalp veins, and more rarely hemorrhage from the malformation. So this is sort of a classic look on an MR with an enlarged central venous structure draining to a falcine sinus. And it's the so-called hair on the head appearance with multiple little feeding arteries coming into this recipient venous pouch. You can see here on the sagittal that, in fact, yes, this structure is a persistent falcine sinus that goes up, as opposed to a straight sinus that goes down along the tentorium. There are variations, and some kids do actually have straight sinuses as opposed to persistent falcine sinuses. But again, the classic description is with a persistent falcine sinus. So to take a bit of a caveat before we get into the treatment, it's important to think about whether you should treat a particular patient. And so this is an example from many years ago at UCSF, 3-day-old girl, severe congestive heart failure and pulmonary hypertension. And she was transferred for emergent embolization, but already had an outside diagnosis of an occipital infarct. And so her MRI done before treatment, I think is very instructive. And you can appreciate, really extensive bihemispheric damage, particularly on the T2. You can see a lot of injury. And then on the T1, this hyperintensity, the white matter hyperintensity is also indicative of really pretty profound pre-existing injury. And so actually, in meeting with this child's parents, we collectively decided that it would not be in her best interest to treat, and she passed. So the classic literature on vein of Galen is really dominated by Pierre Legenius, who was the leading figure in this field. And he not only would treat babies in France where he was located, but he would fly around the world and treat babies with vein of Galen malformation. So he has a huge experience, over 300 cases, and that will probably never be recapitulated by any one practitioner in the future because this is such a rare diagnosis. But I would refer you to this classic 2006 paper in neurosurgery. It really describes his sort of experience over the course of his career really well. And, he started treating vein of Galen malformations with endovascular therapy in the 1980s. And before then, it was an almost uniformly lethal diagnosis. And he starts out this paper again, with that same sort of decision, should you offer treatment or not? And, he uses the term therapeutic abstention for, not offering treatment to particular patients who have a lot of pre-existing brain damage or who have a lot of systemic side effects of massive heart failure that would make them very unlikely to survive treatment. And so he describes this approach, and he developed a score that he named after his hospital, Bicêtre, to try to help folks sort, when a kid comes out and is delivered, should you offer treatment? Should that be immediate and emergent? Can you temporize a child with treating their heart failure, for example, medically, and get them to about 5 or 6 months postnatal, and then embolize when they're a little bit bigger and it's a little bit technically less risky to do embolization? Or are they so terribly sick that really, offering no treatment is probably the right decision? And so he develops this score and adds up the points based on cardiac function, cerebral function, respiratory function, hepatic function, and renal function. And I think it's a useful rubric. We don't follow it, to the letter in terms of, these exact numbers, but I think these categories are really important to think about when you're looking at a kid with a vein of Galen malformation, because it's not just a cerebral vascular malformation you're treating. You're really thinking about all of the systemic effects of that very large arteriovenous shunt. So here are some sort of classic pictures of the two types of vein of Galen malformations. As we'll go on, there's actually a lot of overlap, but people often like to sort them into choroidal types with multiple small little feeders, or as my mentor Chris Dowd used to say, it's like gnats in the swamp. There are all kinds of little arteries flying around the head. And then mural, which are fewer, larger caliber shunts, which generally plug into the side of the recipient pouch as opposed to the anteriormost portion of the recipient pouch. So we did a study several years ago on looking at the angioarchitecture of the cases that were treated at UCSF to that point, about 26. And so what we found is the choroidal type was about a quarter, the mural type was about a quarter, some mix of those was about a third, and some were very difficult to characterize. So in terms of treatment, we've already talked about no treatment. We've talked about temporizing them with congestive heart failure management. And that's why it's really important, if you're going to treat kids with vein of Galen malformations, to have a high-level neonatal ICU and work in concert with the neonatologists and the pediatric cardiologists because of these right-sided overload from congestive heart failure. Surgically, it's very difficult to connect these AV shunts deep in the brain in a very young child. And that's one of the reasons that, before endovascular treatments came along, this was a really, really grim diagnosis. And endovascularly, we can go through the arteries. In the old days, before there were really good catheters, transtorcular was a standard approach. Now, as we'll see later, intrauterine transtorcular approach is an option again, but for many years that was sort of just of historical interest. Transvenous sometime when there's so many little tiny arteries, really all you can do is approach the vein. And then sometimes, your catheter will go through from the artery to the vein or from the vein to the artery. And again, I just emphasize that stage treatment is preferable to an attempt at complete cure. Completely shutting down flow often is complicated by hemorrhage. So again, here's a classic example of a 3-month-old with hydrocephalus. You can see a very large recipient pouch and a relatively small caliber outflow tract. And this is a mural type vein of Galen malformation. And we go through and we place coils into the feeding arteries. This is a case that my partner Chris Dowd did many years ago. These days, a lot of vein of Galen's are diagnosed by MRI prenatally. So people will get a screening ultrasound. There's a suggestion of a large vascular structure, and then an MRI is performed to follow that up. This is a more recent case, and you can appreciate a very large dilated central venous structure, but also other vascular structures which are abnormal. And this child was born with severe neonatal congestive heart failure. We were thinking it was going to be a vein of Galen of some type. And I believe this kid was so unstable, she could not tolerate a postnatal MRI. Basically, anesthesia told us, if we go to MRI, this child is going to die in MR. So we essentially just had a postnatal ultrasound and then went to the angio suite on day of life 1. What's also really helpful is if you know prenatally that a child is going to be born with a potential high-flow vascular lesion, ask your OB-GYN and neonatology colleagues to place an umbilical artery catheter in the delivery room, because having that access is tremendously helpful for embolization and for repeat embolization, because you can sort of exchange an umbilical artery catheter multiple times and do multiple rounds of embolization, and it won't injure, permanent future arteries, as opposed to getting repeated common femoral artery access in a neonate. There's a higher incidence of occlusion of the femoral arteries and potentially leg length discrepancies. So umbilical artery access is a wonderful thing to use in neonates where you know that they may have a high flow vascular malformation that you're going to treat in that neonatal period. Having an umbilical venous catheter can also be helpful, particularly for fluid resuscitation. And in the rare cases, you might want to go transvenous. But really, the most important of the two is an umbilical artery access. So this was that same child, and we did glue embolization of a big connection. I'll show you some more angioarchitectural pictures in a minute. But I also want to mention to you that there are already calcifications lining the ventricles. And this was a child who had a complex genetic syndrome with a partial chromosomal deletion and a lot of other anomalies apart from a vein of Galen malformation. But here you can see glue going partially into the big recipient pouch, for example. These are a couple of Dyna-CT images of the glue cast after that first embolization. Here, we can finally do a postnatal MR when they're a little bit more stable. And again, we appreciate not only a large recipient venous pouch with really no narrowing here, so it would be very difficult to lodge coils in here. And so we've done transarterial glue as the primary treatment. And again, you can see sort of a simplified cortex. This is a kid with a complex genetic syndrome. And it's a complex vein of Galen malformation because it also includes MCA branches being sucked in, which is really quite unusual, right? And so here you can see in a common carotid run, multiple MCA cortical branches getting sucked down into the recipient venous pouch. So more complex than your typical vein of Galen malformation. We did additional embolizations in that neonatal period in order to reduce shunting and further reduce heart failure. And she ultimately did well clinically. She has a lot of developmental delay related to her chromosomal anomaly, but her family is tremendously grateful and they love her, and she's now about 3 years old. And so that was a success in terms of the goals of the family. Here's a 6-month-old who had a vein of Galen and diagnosed with a RASA1 mutation. And RASA1 is probably the most common mutation underlying vein of Galen malformations. Some can be related to some of the other HHT-related mutations, which we'll get into a little later in the presentation. But we'll do genetic testing in all of these kids who have these malformations. So here was an initial CT, and you can see this classic colpocephalic appearance where you have very dilated lateral ventricular atria with sort of a paucity of white matter around them. You can see again that central recipient vein. And on the MRA, again, you can see a persistent falcine sinus. It actually has a couple of channels as opposed to a straight sinus. This was her initial sagittal view. And she was actually temporized with a ventricular peritoneal shunt because of enlarging head size. This can be an okay temporary solution, but it's not a good long-term solution. And if you think about it, the reason that most of these kids with vein of Galen malformations are getting hydrocephalus is not because the recipient pouch is pushing on the aqueduct and causing obstructive hydrocephalus, it's actually because of the high arteriovenous shunting, the intracranial venous pressure is extremely high. And so it's an underabsorption form of hydrocephalus. And so if you then lower the CSF pressure, it actually doesn't treat the underlying problem. And, chronic ventriculoperitoneal shunting in these kids can lead to a lot of white matter calcification and worse brain damage. Really, the way to treat the hydrocephalus definitively in kids with high flow shunts like this is to treat the arteriovenous shunt, not to just remove CSF. So this is what she looked like after placement of the VP shunt. And again, you can see that that has reduced the ventricular size. We do have, a fair amount of encephalomalacia back here and low white matter volume. And so at this first embolization at about 6 months of life, this again has a big recipient pouch. And the venous outflow tract is an important metric that we'll talk about a little bit more later in the talk too. But, an almost 10 millimeter venous outflow tract, sort of indicative of, the high volume of flow that's going through here. This was a case where we went through artery 2 venous pouch, came back and, coiled off these big mural connections with multiple detachable coils. And we tend to like coils at UCSF because they're very, very controllable. We use glue in, very high flow situations with very tortuous feeding arteries, sort of like I showed you in that first case. But when we have the option to use coils, we like to use coils. So now you'll see after the first round of embolization, she comes back and look how much smaller that venous outflow tract is. So that's a nice proxy for, yeah, we're really reducing the arteriovenous shunting. We're reducing the burden on the heart, for example. Again, multiple staged embolizations over time. And now we're finally getting to the ACA feeders. You'll often get sort of multiple limbic arch feeders to this. And so not only do you get choroidal type feeders, but you'll often get distal ACA splenial type feeders to these malformations as well. And what's interesting is they'll come around the spleen and then they'll come all the way to the front part of that pouch. So you often have this very extensive course of the feeding artery before it actually dumps into the malformation. And here we use glue to seal that off. And you can see that the arteriovenous shunting has essentially been eliminated on MRA. So let's talk a little bit about outcomes. So for folks who present as children with vein of Galen malformations, a lot of the data is sort of lumped together. And, if you want to try to tease out which subgroups do better and which do worse, if you present as a neonate with heart failure, that's really predictive of poor outcomes. And in fact, even in Pierre's paper, I think as we'll see, about 50% of kids who present in that neonatal period ultimately died despite embolization. When you lump the whole group of vein of Galen malformations together, both neonates and children, then the numbers are a little bit more encouraging. And you'll note, again, in a lot of these, you don't get complete occlusion, but you're getting kids out of heart failure. You're reducing that flow. And a decent number between half and 2/3 can have a good neurologic outcome. So again, this is from Pierre's paper, breaking it down by neonates, infants, and children. And again, I want to emphasize, this really severe group, half of kids who were treated in the neonatal period in his very skilled hands died. And, we've seen this as well. And so this is really the motivation for, as we'll get to later in the talk, thinking about prenatal treatment. So this is a really wonderful diagram from Pierre's paper in thinking about, when you want to treat kids. And so if they've come out and they're in congestive heart failure, you need to treat them promptly. But if they're not in terrible congestive heart failure and you can temporize them, really the sweet spot to treat them is between about 5 months and a year before they've developed problems from chronic venous hypertension like white matter calcifications and that sort of stuff, which can lead to neurocognitive problems. But they're big enough that treatment is a little less risky than when you're in neonate. So again, just an example of somebody who had been shunted and their vena Galen malformation had not been sufficiently treated, and they got, sort of chronic venous hypertension and a lot of white matter injury that you can see from that subcortical calcification. Here is a confounder, a so-called false vena Galen malformation, and you need to be aware of this. At first you're like, oh, look, there's a big pouch. It must be a vena Galen malformation. But if you look closer, you see there's actually an off-midline nidus of vessels. So this is actually just an arteriovenous malformation that happens to drain to the vein of Galen, and the vein of Galen has secondarily become very, very dilated. Now, it does still have a persistent pulsing sinus, so probably that happened relatively early in development. But you need to treat this like an AVM as opposed to like a vein of Galen malformation. And you're going to need to treat the nidus itself as opposed to thinking about treating, the venous portion, for example. So here's another case with another sort of false vena Galen because it's slightly off midline. Again, at first blush, you're like, oh yeah, there's a central recipient big vein, but it is sort of off midline. The connection is close to midline, though. And on the MRA, I think it's quite helpful to see that these often have a retiform angioarchitecture. And so these feeding arteries break up into a rete, but then they can recombine into a single final common pathway before dumping into the recipient vein. And so we call this more of a choroidal AV fistula as opposed to a true vein of Galen malformation. But what's nice is once you analyze this angioarchitecture, you can say, yeah, there really is just one artery that plugs into the vein ultimately, even though it's broken up into sort of a cluster of arteries, they join back before dumping into the vein. And so with that architecture, you can get to the final common arterial pathway and coil the arteriovenous connection itself. And in that single treatment, you can cure this. And so that was a very satisfying case. Now, not everything is going to progress and become worse. We have seen spontaneous regression in vein of Galen malformations too. And again, I think if you identify a vein of Galen malformation and the kid is not in heart failure and they're not demonstrating, hydrocephalus or evidence of sequelae, you can follow these. And so this was a sort of a neonatal MR angiogram, and it definitely looks like a vein of Galen malformation. But we followed this up a few months later, and you'll notice that the flow is much, much less. And then, by about a year, we said, gee, maybe this is gone. And so here's an angiogram at about a year, and there is no malformation. So they can regress on their own as well. And we don't know how frequently that happens. So to finish the vein of Galen portion of the talk, I'd just like to highlight the really amazing work that Darren Orbach and his colleagues at Children's and Brigham and Women have been doing in the last few years. And they have pioneered an approach to treating vein of Galen malformations, the really big ones, in utero. Because of that notation, from Pierre's work and our work that, about 50% of kids who present neonatally with heart failure, they will die despite your best efforts. And what Darren's group did, which was really nice, is they looked at a lot of their vein of Galen malformations. And essentially, if you have an outflow tract in utero that's above about 7 millimeters in diameter, there's about a 95 to 98% chance you will go into florid neonatal heart failure. And so that subcohort of 7 millimeter and greater outflow tracts can be enrolled in his clinical trial. And I think it's really important to send kids who have these really big outflow tracts to Boston so that he can complete the clinical trial in a controlled manner. But basically what the technique is that he's able to do with his fetal surgeons is percutaneously get a needle into the vein of Galen, going transtorcular and up the persistent falcine sinus, and then put coils in. And it's all under ultrasound. And so basically you're just seeing a lot of this white shadowing as your, detachable coils are going in. And again, the goal is not to eliminate all flow. It's just to significantly cut down flow. And from his first case there, that kid did really well. The membranes did rupture the day after, and so the kid had to be delivered just a couple days after the treatment. But now the kid is almost a year old and is doing really, really well. And he's had a couple of other cases that he's enrolled since then. And knock on wood, so far they've been doing well as well. But one of the main risks is that when you do this procedure, even though you're using good transuterine technique, the membranes can rupture, and the child may have to be delivered, shortly after your procedure, as opposed to, I think, how he originally conceived of it. We'll do this coiling, and then the baby will stay in for a few more weeks before being delivered. So let's move on to a slightly different diagnosis, a non-galenic pedal arteriovenous fistula. This really almost looks like sort of a holohemispheric AVM in a young kid with a cranial bruit. And I think there is probably a continuum. When do you call it a multi-connection or multi-hole non-galenic arteriovenous fistula and multiple PL AVFs? And when do you call it an AVM with a sort of, a massive nidus? I would say in general, there's no specific cutoff, but really big arteriovenous connections like this, I tend to still call fistulae as opposed to AVM. So here's another one with CHF and a big hemispheric multi-hole non-galenic fistula, but had pretty significant underlying parenchymal injury. On ultrasound, you can see a lot of relatively high echogenicity, which tends to connote that there's parenchymal injury, adjacent to all of this high flow stuff. And again, you can see, shrinkage of this hemisphere relative to this hemisphere, and a lot of, high signal, again, probably indicative of injury. The kid is in heart failure. And so here's the MRA. And again, you can see multiple big connections in that left hemisphere. But we did the MR, and you'll note, not only the big connections in that left hemisphere, and a lot of encephalomalacia and shrinkage in that left hemisphere, but the right hemisphere is not normal either. There's a lot of damage in the left hemisphere, but the right hemisphere is not totally intact either. The injuries are a little bit more subtle there. So we had a long conversation with the parents, and they opted for therapeutic abstention. And I think what struck me with this is when we decided to go for comfort care in this kid, our pediatric cardiology colleague said, yeah, when we sort of discontinue the support, it'll probably take several days for the kid to pass away. When they turned off the support, this child actually passed away within about 20 minutes. So these are very high flow lesions, again, that are presenting with heart failure, and the kids are quite unstable. So if you look at non-galenic fistulas, which present really early in the first month of life, that was about 8 out of 23 in a cohort at UCSF we published about a decade ago. Most of them had congestive heart failure and very large complex fistulas with multiple sites of shunting. One was more of a syndromic diagnosis with segmental cutis aplasia and a hemangioma, for example. And here's an example of that. With a malformation that fills almost all of the posterior fossa. And again, you can see multiple large caliber connections on the arteriogram and multiple dilated veins on the venous phase. So here's another kid with a posterior fossa non-galenic fistula, a more recent case. Again, you can see a very large torcula. You can see very dilated vessels, which are draining veins. So you know that the connection is going to be not in the torcula itself. It's going to be anterior to the torcula and multiple dilated arteries. Again, when you do the MRA, you see the very large recipient torcula and a superimposed vein just anterior to it. Again, because we knew from a prenatal MR that this kid was likely to come out and have heart failure due to that big malformation, we had arterial access through the umbilicus. Here's the initial arteriogram on day of life 2. And you can see dilation of the vertebral artery, the basilar artery. This is the pica here. And this is one of the SCAs, which is going to be very large here as well. Both SCAs in this kid were massive. And one of the picas, AICAs, was massive, as was one of the picas. And so here we navigate out with a flow catheter. And another point I'd like to make that's important in neonates is that their arteries are delicate and the connections between the arteries and the brainstem are delicate. So we used a flow catheter here. This is a 1.8 volt Magique flow catheter. We do have a wire in it, but it's a pretty floppy wire. It's like a 008 Chick-Eye wire. And one of the most dramatic cases I saw when I was a fellow was a kid with a non-galenic fistula who my colleagues were trying to navigate out the distal PCA to access a shunt site. And they were using an SL10 microcatheter and a transcend wire, so a stiffer system. And, the basilar artery went from, highly curved to straight. And, that stiffness of that catheter and wire had avulsed the basilar artery off the brainstem, tearing the perforators, and the child died in the angio suite. So in neonates, I tend to be very careful about distal navigation in very tortuous arteries, particularly when they're attached to the brainstem. So I tend to use flow catheters in the posterior fossa for that reason. So this is the glue cast in that massively dilated SCA. We did the same thing in the other SCA. And one of the AICA connections, here's that glue cast. He did have some postoperative bleeding, but he recovered. And here's a follow-up at 8 months. And we used sort of modern MRA flow techniques to look at residual flow in the malformation. And it's just kind of academic interest at this point. But, using quantitative 4D flow MRA may be a nice way of tracking the decrease or increase in flow in a malformation over time, particularly when the goal may not be cure immediately. It may be, staged embolization. So here's the other type of non-galenic fistula that we see in kids, which is the single hole, or single connection. And this is sort of a classic one with a massive varix. It's obviously been there for a long time. You can see calcifications in the wall of the varix. And what's nice about these is you can often get out to the single connection, put coils in it, and cure it that way. So that was the bulk of those 23 cases, about 15 of them. Most of them were single hole in these older kids. And they presented in different ways, not with CHF, but seizures, headaches, a focal neurologic deficit, and a minority with hemorrhage. So if you look at non-galenic fistulas in kids, what are those outcomes as compared to vein of Galen's? And they're actually, fairly similar overall. Again, about half you can expect no neurologic or developmental disability if you're able to treat them. So here's an example of an 18-month-old who had a neck lymphatic malformation, and so they were doing neuroimaging related to that, and this is a more recent case. And here's the MRA that then was prompted after they said, oh, there's something in the head. And you can see a very large vascular structure here and dilated arteries associated with it. On the lateral, it's a little more easy to appreciate, the PCA is extremely large. There's a big varix, but these branches of the MCA are like splayed around this thing. So here's an angiogram that was done at an outside hospital. And again, you can see massive enlargement of the PCA, this flow jet into the big recipient pouch, and then drainage through this vein into the transverse sinus. So again, somebody at an outside place said, okay, I'm going to try to coil that. And this is what happens when you try to put like regular coils into a high flow malformation. You can see it's just like flapping in the breeze. So, appropriately, he said, I don't treat these often. I'm just going to stop. And so the kid was sent to us after that. So again, here's a picture of that sort of high flow connection, into the varix. And here's the lateral. So what's instructive here, and often what you'll see in big high flow fistulas, is if there is a shelf or a narrowing between the artery and the vein right at the arteriovenous connection site, you can take advantage of that to try to lodge coils in there. Alternatively, you can glue these things, but again, I like the controllability of coils. So if there is a natural narrowing between the distal artery and the vein, I will work pretty hard to try to get coils to lodge there. And so that's what we were able to do in this particular case. What's also interesting, again, it's this retiform angioarchitecture, because here's the MCA, and you can see this branch of the MCA come and fuse with the PCA, and that's a final common pathway. That's the same shunt I just showed you from the PCA. So here again, we see that relative narrowing just before it dumps into the big recipient venous pouch. And so here, we use the Penumbra PC400 coils, which are the biggest, sort of thickest commercially available coils that we have. And, you put the leading part of the coil in, and then you pull your catheter back just proximal to that natural ledge, and we're able to make that coil sit and form in there. And so that was very satisfying. And we said, yeah, we took out the big shunt. That's awesome. And we thought we were going to get a cure based on that. And again, this again confirms it's a final common pathway because it's coming up to the coil mass. So what was interesting, at 4 months, we had taken out the big shunt, but it unmasked a smaller shunt. And so here's what the MR looks like. Here's that thrombosing varix. We're pretty happy with that. But interestingly, we use arterial spin labeling, which is a non-contrast perfusion technique on MR. And I'm just wondering, why is it still bright next to the varix? Maybe it's just, heterogeneity of the scan, but it did catch our eye like, there is, some higher signal associated with that thrombosing varix, which we didn't really understand. And then as it turns out, if you'll look, there's actually a little associated AVM nidus, and there's still shunting to this vein. And I won't go back, but this shunting vein was there when the giant varix was there too. And so I think what we've done is we've taken out the massive arteriovenous connection, but there's still some little arteriovenous connections. And that's often what you'll notice is when you have a massive shunt next to some small shunts, you can't see the small shunts when the massive shunt is still there, but once you take out the massive shunt, then you can start to see the small shunts as well. And so here it almost looks like a little bit of AVM nidus going to that draining vein. And that kid's going to come back soon, and we're going to have to decide, do we gamma knife that? Do we resect that? If it's hypertrophied a lot, maybe we would consider embolizing it. But again, satisfaction of search is something you have to be aware of. Try to take a step back and say, okay, I'm going to ignore the giant shunt. Are there other little shunts that I can see? So then going on to dural fistulas, these can have very high flow rates, and they can, have a higher mortality than the Peel shunts and the vena Galen shunts. And, these often will result in like the biggest turculas you've ever seen. So here's a more benign example. This kid had a pulsatile thrill behind his ear. He got a neonatal MRA. You can see this very dilated transverse sigmoid sinus with enlarged arteries. At a couple months of age, we bring him to the angio suite because his head was getting bigger pretty quickly. And what you can see is occlusion of his sigmoid sinus and ECA branches plugged into the transverse sinus and causing retrograde drainage across to the other transverse sinus and out an ipsilateral sinus as well. An occipital sinus. And so here we basically said, well, there's no antegrade drainage out the sigmoid sinus. There were no cortical veins that plugged into this segment. And so we're just going to coil that final common pathway up. We came up transvenously and took out the final common venous pathway with coils, and that cured it. And the kid has done well. He's 6 years old and is normal. This is him at 4 months as well. And one thing that you will notice is that in the venous phase, a lot of these veins, because of that period of intracranial venous hypertension, are very curvy looking, or the so-called pseudophlebitic pattern. And even though he's normal and his brain is developing normally, he still does have extra curvy little cortical veins. And I used to ascribe more to that, seeing him develop totally normally. I think it's just a feature of people who've had venous hypertension. It doesn't necessarily mean anything bad is ongoing. It just may be a residual appearance because these veins at one point in their existence had to handle higher flow and pressure. So that's a sort of congenital type dural fistula in a kid. Here's an adult type, if you will, dural fistula in a kid. So she's 10 years old, and she'd had to have a bone marrow transplant because of lupus. And she came in for an MR, for a CT, and there were too many vessels in the posterior fossa, too many on the MR. And she has a dural arteriovenous fistula that has MMA and posterior meningeal feeders, and the fistula site is near the torcula to these cortical veins, and so it's a high risk fistula because you're pressurizing hemispheric cortical veins in the cerebellum. And so here you can sort of treat it as you would treat an adult type dural fistula. You navigate a catheter out and you just onyx the final common pathway, and that cures it. So there is a phenomenon of progressive or runaway dural arteriovenous fistulas that we wanted to look at, and we, among our cohort of about 600 patients, found about 34 who had de novo, enlarging, multiple, or recurrent dural fistulas. And then we further broke it down and looked at the people with de novo or enlarging dural fistulas over time. And what's interesting is the progressive dural fistulas, de novo and enlarging, they tend to skew more to the younger ages than the older ages, for example. And this was a particularly evocative case of a person who originally was treated in the Philippines when she was a teenager with just coiling of ECA branches, and she had a progressive skull-based dural fistula. And we first met her in her early 20s. And you can see these massive sort of shunts at the skull base. And here over time, you can see hypertrophy of some of these branches and progression over time. For example, this branch was quite small, and then she came back over time and it is hypertrophied. Unfortunately, there are some of these runaway dural arteriovenous fistulas that can be very difficult to control. And the natural history of those, despite maximal sort of embolic treatment, is progressive intracranial venous hypertension, intracranial hemorrhage, and death. This is a more recent case of that, which was very sad. And I won't go through it in excruciating detail, but I'm just showing you sort of a montage of multiple high flow shunts in the skull base that, he had a lot of staged embolization. I will call attention to the brainstem. That will become important later. You can see a little bit of vascularity in the brainstem there, but no hemorrhage, no edema at that point. But eventually he came back and look, we're starting to get this interesting little edema in the pons. And he still didn't have brainstem symptoms, but then he came back later with a pontine hemorrhage and edema surrounding it, and he was locked in. At that point, there was even more, venous hypertension of the brainstem. We did really extensive embolization to reduce the venous pressures in the brainstem. And this ultimately organized to look more like a cavernoma. It's just sort of chronic hematoma. But we actually reversed his locked in symptoms, and he got off the ventilator and he was able to go home after that. But you can see all of this extensive embolization over time. Eventually, he succumbed to his disease as well. So if you look at all the different categories, dural fistulas do tend to be the most complex and have some of the highest mortality rates and some of the lower likelihood of having a good neurologic outcome. So then just briefly about arteriovenous malformations, which are more common than all of the things I've been talking about. They can present in neonates and infants with CHF, but more commonly they present in older children, sometimes with smaller niduses as compared to adults, but then again, kids are smaller than adults. They have an increased frequency of presenting with hemorrhages compared to adults, and an increased frequency of intraventricular hemorrhages compared to adults. So here's sort of a classic, intraventricular hemorrhage related to this corpus striatum AVM, for example. And several papers have looked at presentation in children as compared to adults. And again, they have some of these same sort of high-risk features that are seen in adults for bleeding, deep venous drainage, supply by perforators, nidus aneurysms, multiple aneurysms, posterior circulation, and basal ganglia. But again, interestingly, in kids, there's some suggestion that a smaller AVM nidus actually has a higher frequency of presenting with hemorrhage than a larger AVM nidus. And so we looked at our cohort, again, about a decade ago. and compared adults to children. And again, this may be the demographics of California, but there was a higher percentage of Hispanic children as opposed to adults who were presenting with AVMs, and a higher percentage of kids presenting with hemorrhage, about 59% versus about 41% in adults. And interestingly, even though kids were more likely to present with hemorrhage, they had a lower rate of having feeding artery aneurysms related to shunt flow. And so perhaps it takes some time for vessels to be damaged by high flow to develop these aneurysms. Here's a cute little aneurysm, actually, the source of this intraventricular hemorrhage, and it turns out to be a recurrent artery of Hubner feeding artery aneurysm that was the source in this kid. Here's a splenial hemorrhage with intraventricular hemorrhage associated with it due to this large pseudoaneurysm associated with the nidus that was ethanoled for cure. Venous ectasia, similarly, is a high-risk feature, but it's at a lower rate in kids than adults. So again, it may take time for high-flow features to show up in AVMs. As we know, should you treat brain AVMs or not? You know, some of the numbers that I keep in my mind, if an AVM has ruptured before, it probably has at least a 4 to 6%, and some would say 10 or more percent annual re-rupture rate. And so we tend to offer treatment for ruptured AVMs for pretty much everybody. For unruptured AVMs, it's a more nuanced discussion if you use that 1 to 2% annual rupture rate. But again, because kids are going to have decades to live, we tend to err more on the side of treating, or at least offering treatment, than not offering treatment. And particularly for small kids, you know, again, if they're below about age 5, it's hard to put them in a gamma knife frame. So often gamma knife comes into the conversation once kids are 5 and older. We're all familiar with Aruba, which was that randomized treatment of unruptured brain AVMs. And of course, the trial was stopped early. And, you know, people who got active treatment, the blue line, they had all their complications up front from the treatment, whether surgery, gamma knife, embolization, or a combination. Whereas people who didn't get treatment, you know, they're slowly accruing intracranial hemorrhages in a stepwise fashion over time. Eventually, do these lines cross? Yeah, probably at about 18 years. And that's the more 18 years after the initial measurement. And so if you have a life expectancy of more than about 18 years, then we tend to offer treatment for folks these days. And that's the MARS data that was presented at the International Stroke Conference about a year ago. And we're working on the manuscript to publish that. You know, Aruba, again, had all of those challenges, sort of short follow-up for a long-term disease. Another point, particularly for kids, is that they can have recurrences, possibly because they have more of a angiogenic drive and ability to form new blood vessels. And so here's a case of a diffuse AVM in the cerebellum. It was resected, looks cured on post-op angio. And here they come back a few years later and they've got a recurrence. And so we actually found up to about a 10% recurrence rate in previously ruptured AVMs that were resected within about 5 years. That goes along with the Australian data that Michael Morgan presented several years ago, that, you know, if you had deep venous drainage, for example, you were much more likely to represent than if you didn't. And so we actually looked at our recurrence data and saw those 12 recurrent brain AVMs out of 115 who apparently had cure, and sort of a complex diagram of how people were treated over time. But the main takeaway is that unruptured brain AVMs, they had a very low recurrence rate after apparent surgical cure. But for those that originally presented with rupture, there's a pretty significant recurrence rate within about 5 years. And so that's why we've taken the approach now, after apparent cure of a brain AVM in children, we'll do a 1-year post-op angiogram and then a 5-year post-op angiogram, just to make sure we're not missing any of these late recurrences. So now briefly, just a little bit about HHT. Because we run a big clinic in this, it's a genetic condition, autosomal dominant, about 1 in 5,000 people, associated with forming AVMs in multiple different organs, brain, lung, and liver primarily. And Aruba doesn't apply to this because HHT specifically was excluded from it. And many of these AVMs can be very, very small, but it's hard to know what the rupture rate is. And some studies have suggested 0.3 to 0.5% per year per patient, or 0.4 to 0.6 per lesion. Some of these patients can have 10 small brain AVMs. So this is why in HHT patients, we actually will screen kids with MRI as soon after birth as we can for a brain AVM, and then every 5 years until they're age 25, so that we don't miss a brain AVM forming in these young people. Once you've had a normal brain MRI at age 25, we think you're very unlikely to form a new brain AVM in adulthood. But there are several case reports in the literature about forming new brain AVMs. This is one from the literature, not in an HHT patient, but again, I think you can appreciate really nothing callable there. Maybe there are two little vessels there, but you'd never prospectively call it. But here, 8 years later, you have a full-blown AVM confirmed angiographically. Here's another one from the literature. Again, nothing at 1 year old, but by the time you get to be 7, here's an AVM. Similar 7 years versus 16 years. This has been reported in HHT as well. So here was a kid who was screened at 5 months, didn't see anything, came back for a 5-year scan. Here's a pretty classic AVM. So we've toured the pediatric shunting lesions in the head. One last little mention about spinal fistulas too, and this again is just highlight what is your approach to subarachnoid hemorrhage. Here's a kid who comes in with interventricular hemorrhage and transient paraparesis, a little bit of hydro related to that fourth ventricular hemorrhage. So in the workup of posterior fossa hemorrhage, we always will shoot the posterior circulation, and we will look at the blood vessels in the neck as well. So we do a neck image of the vertebral arteries. And that's important because occasionally you'll see something like this, where you actually have a vascular malformation in the spine that has bled, and the blood is percolated up into the head. And so here is an enlarged branch of, I believe, a costocervical artery that has gone to a perimedullary fistula. The AV fistula site is on the surface of the spinal cord, and here are the recipient veins. And then on the later phase, they fan out into a lot of intrathecal veins that then decompress into the epidural plexus. So again, here's that costocervical single artery, dilated vein coming out. And so again, this is type 4 perimedullary fistula. Again, a single hole fistula on the surface of the cord. And you can see, a large percentage of that spinal canal is full of blood vessels. The spinal cord is sort of bananaed up in front. What's nice about simple architecture like this is you can just navigate through, start coiling in the venous varix, and come across the arteriovenous connection to the distal artery, and that should cure it. And in that case, it did. So in conclusion, I think, for neonatal CHF cases, you really have to have a lot of attention to the cardiovascular and hematologic issues. And so it's really important to work with a very experienced team. You want to minimize X-ray dose and contrast to the patient. And we use endovascular therapy for a variety of vascular conditions in kids. Finally, I'll just mention, if you're interested in pediatric cerebrovascular research, we did establish a small fund within the Society of Neurointerventional Surgery to help make grants for trainees who are interested in researching cerebrovascular disease. So thanks so much. Be happy to take any questions.
Yes, again, thanks, Dr. Hetts, for that tour de force of all the pediatric CNS vascular lesions. I'm going to take some questions from the chat as well as open it up for the panelists that are on with us.
So yeah, that's great, Steve. I'm curious if you have any additional thoughts or information about the de novo AVMs in the young adults, and what's going on there that's different from the the bulk of AVMs that we think are congenital.
Yeah, I think that's a really good question, Cameron. And what's interesting is for nidus AVMs, except for like that one case that showed up as like a false vein of Galen malformation, um, I'm not sure I've ever seen a report of a nidus type AVM in a fetus. You know, we see bigger fistulas, but it may just be a spatial resolution thing. But they may show up in childhood, and they seem to show up progressively as kids get older. So, you know, I think nidus type AVMs, they may start in utero, but I think they grow during childhood and then they present. And so, you know, I think it's a question of sort of detection, right? And so even though you may have tiny little AVMs or tiny little vessels that are abnormal, even when you're born, it may take some time for them to grow to be big enough to be detectable. And there's certainly some conditions that predispose you to that, like HHT, where we see these multiple brain AVMs and we've seen things over time. But a lot of those cases that I showed from that case report paper didn't definitely have HHT. So I don't know why those in particular developed over time. I don't think we know yet. And I think, you know, these sort of emerging genetic studies of like somatic mutations like KRAS and some of these other things are going to be really interesting to figure out, yeah, what is the second hit in somebody with the first hit like HHT that causes an AVM, or what are the two independent hits that are, you know, potentially happening to cause sporadic brain AVMs?
Yeah. Are there any clues in the recurrences after hemorrhage that you resect? And I mean, I always worried when I saw AVMs that were really diffuse, you know, and the nidus didn't seem as well defined in a young person. You know, and the margins weren't as clear. I always thought that was kind of an AVM that was in the middle of forming, and so you were really kind of stuck.
Yeah, I think that's a really good point, Cameron. And you know, the cohort we analyzed wasn't big enough to definitively say like, oh, diffuse is worse than compact. I think that intuitively makes a lot of sense. I think the other thing, and that's what I was trying to allude to with Michael Morgan's paper too, is I think relatively more of the recurrences were on sort of the deeper aspect of the resection cavity. And I think people, you know, rightly are very sensitive. Often there are eloquent structures deep. And so that tended to be the area where there were some more recurrences.
Yeah, yeah, makes sense.
Can you speak about, I know you talked about atmospheric effects related to vascular malformations and HHT, or how that plays into de novo?
Oh, interesting. Yeah. So atmospheric effects, we've published about that more in relation to the nosebleed aspects, like humidity and stuff like that, and as opposed to the brain AVM. So folks with HHT also get telangiectasias in their nose, and one of the cardinal features is chronic recurrent spontaneous epistaxis. And what's kind of fun, you know, operating in San Francisco, kind of like you guys in Seattle, like we're next to the ocean, it's humid, you know, some people live at the beach and like, you know, they don't get many nosebleeds because it's very humid. But we also have a catchment that we get people from the Central Valley in California or up in the mountains in Nevada, and like it's high and dry, and they have like nosebleeds all the time. And so, you know, the dry air and the hot air, things like that, can make the nosebleeds a lot worse. And because, you know, folks with HHD have about a 10 to 20% risk of having a brain AVM, you know, now more and more when we get a kid with a brain AVM or an adult with a brain AVM just coming in, and we'll always ask them, do you have nosebleeds? And so we do, you know, and if you do, you have a brain AVM plus nosebleeds, that's two of the Curacao criteria for diagnosis of HHT. So it's possible HHT at that point. So then we'll do genetic tests on these people. So more the utility is like, I think it's helpful always to ask if you have any brain AVM patient, just ask them if they have recurrent nosebleeds. And then if they do, it's easy to send a genetic test to see if they have HHT. And the reason that's important for them is they might also have pulmonary AVMs. So they should probably have an air filter on their lines, and they may need embolization of pulmonary AVMs to prevent embolic strokes, for example, but also for their family planning, right? And there are other people at risk for AVMs.
Thanks. And I know you
Wow.
talked any of these procedures, especially for the earlier lesions you were talking about with vein of Galen, are all staged. What's in your experience, like how much do you treat at any particular time? Like what's your goals? You know, can you speak a bit about that to the viewers?
Right. I wish I had an easy answer to that. Sort of the tongue-in-cheek answer is like, you know, well, 1 milliliter of flow less than it takes to induce a hemorrhage, right? So what you want to do is you want to reduce the flow enough that it gets them out of heart failure. And it's really a negotiation almost with your ICU team of like, are they enough out of heart failure? Can we temporize them? Usually if there are big connections and smaller connections, you'll target the big connections first. And so they tend to have relatively more physiologic effect, more bang for your buck than the smaller ones. And so often in malformations with multiple connections, if you take out the biggest few connections in 1 or 2 or 3 neonatal embolizations, that's enough to get them out of heart failure that they can then be temporized, and then they can come back at 6 months and potentially get some additional embolization. One of the interesting things that's also come up recently is now we have some kids who are like teenagers, and we've eliminated like 95% of the flow. And then the question is, do we need to get rid of that last 5%? Like, do they present a risk for hemorrhage in the long term? And there it's a little bit uncertain whether they do or not. Because once you've taken out all of the easy to embolize connections, again, here's an adage that, Cameron and my great mentor, Van Halbach, used to like to say, it's like showing up at 4 p.m. at the yard sale. All the good stuff is gone. And so, are you going to, take a lot of risk to get rid of the last little bit, even if you're not sure like what risk that last little bit presents to the patient? And that's where I think there's a lot of uncertainty. And we have a few patients where there's some tiny little residual and we're like, well, we can't really get out there. Should we just gamma knife the last little bit or something?
And I know
for me, Cliff, with the neonates and failure, the real rate limiting step in terms of how much you embolize was volume overload. The tiny babies can tolerate so little volume. You're always worried about contrast overload and how much contrast you can give them, but most of the time it was once we got better at roadmaps and using the MR and all that sort of stuff, we weren't so limited by the contrast, but just the volume was a limiting thing. You just had to diurese them.
Exactly. And, we'll try to consciously limit, these neonates off, and you get like 15 cc's of contrast for the whole case. And,
Right.
Instead of having a regular drip, you use those, micro squeezy drips. And you're exactly right. And then your anesthesiologist will tell you basically like, we can't diurese this kid anymore. You need to stop.
Yeah. Yeah. Back to the HHT. I was interested in the MR screening for the brain AVMs. How sensitive is that, and how do you ever sort of like get a baseline angio with somebody who's had an AVM, and which AVMs in the brain are you treating with the HHT patients? What are you doing with the patients who have 3? The 10 is kind of an easier thing because it's like I can't treat 10, but
yeah, so great question. Yeah, we have a big HHT clinic, and so that's been a really gratifying part of my career. I've really enjoyed getting to know that population and think about these things. So, we use MR as the screen, and if there's anything that's suspicious, we will then do a catheter angiogram to confirm or deny that what we saw on the MR is an AVM. And it's not infrequent that, the MR may identify 1 or 2 things that might be AVMs, and then, you do the angiogram, and because it's so much more sensitive, you come out and you're like, actually, you have 4 AVMs. And so we'll then have a talk with the patient, like, okay, if the per lesion risk is something like this, and, you're a young person, how do we treat these? And, some are bigger, and, they may have classic high-risk features like phenol aneurysms or venous outflow stenosis. And there we may lean more on the let's do surgery, let's do embolization and surgery. But for a lot of the really little ones, and particularly if they're a little bit deeper, we do a lot of gamma knife. And so we've treated a lot of folks with gamma knife. And what's nice about gamma knife is you can target multiple lesions. I agree, 10 is a bit much, but it's not infrequent that we'll target like 3 or 4 small brain AVMs in HHT patients. And, there's a very high cure rate because they're very small. And I think the question that we'll start to answer with the HHT population that we can't in the sporadic AVM population is, in addition to those classic angioarchitectural features for future bleeding, is family history of bleeding a risk factor? So we're trying to ask our patients, like, hey, did your mother have a brain AVM? Did it ever bleed? And like, does that put you at risk for bleeding? So you can actually ask a family history of bleeding question in these people that you can't ask in a sporadic population.
Oh, interesting. But getting back to the actual sensitivity, I mean, you say there you've seen something suspicious on the MR and you do the angio and you see 4 instead of 1.
Yeah.
I mean, is there a case to be made for getting an angiogram as a baseline in every sort of HHT patient that you identify?
Yeah, I think because it's an invasive procedure, there'd probably be some resistance to that. There are a couple of patients I can think of who had a very strong family history, and they essentially demanded an angiogram, even though their MRIs were normal. And, in those 2 people, I found nothing. It's hard to know, when the MR is normal, what the additional sensitivity of that catheter angiogram is going to be. So I don't tend to offer an angiogram if there's nothing on the MR that's suspicious. But suspicion on the MR, like some are pretty subtle, like, oh, there's just a little micro hemorrhage or something. It's like in a non-HHT person, I'd be like, whatever. But in them, I've been like, okay, there's actually a micro AVM associated with it.
Cliff, did you clean out the chat there?
Yes, I did, and I checked YouTube. I didn't see any other questions.
All right, we've kept Steve longer than we promised. It's great to see you. Really appreciate you being here. Enjoyed your talk, and hope to see you again real soon in person.
All right, thanks so much, guys. You have a great day. Bye.
You take care. Bye now.